Hello, my name is Ruiz, and today I will be presenting on my final project, Bridging Care for Mothers with Polysubstance Use through the MCH lens. I will walk through a multi-level plan to improve outcomes for mothers with polysubstance use. We'll move from the problem statement to social ecological model and context, the three interventions I've placed, evaluations, barriers, partners, and a concise logic model. We're going to start off by defining the problem. I'll begin by discussing the maternal and child health issue here. I have chosen the issue of polysubstance use in pregnancy. It is an issue that is rising but remains underserved compared to the opioid-only responses where programs and policies have been built for much longer. Additionally, there are only a handful of states that offer dedicated programs for pregnant people with substance use, and many actually exclude polysubstance users. Factors like living in rural areas, being in lower socioeconomic classes, such as poverty, and stigma have magnified the risk of pregnant people, while there is still inconsistent data on what is actually going on. To my right here, I wanted to quickly present these two figures. They look at polysubstance and how it's increased in a specific group since the early 2000s. This data was generated based off an analytic sample that included over 170,000 delivery hospitalizations in the US between 2007 and 2016. In figure 1, what we look at is among women with opioid use disorder and co-occurring substance use at delivery has increased significantly over time. Polysubstance use among those with opioid use disorder has increased from 60.5% from 2007 all the way up to 64.1% in 2016. Figure 2 looks at urban counties versus rural counties in the same manner. The average predicted probability of polysubstance use among those with opioid use disorder diagnosis at delivery increased at a much faster rate in rural counties relative to urban counties. In rural counties, 60.4% to 68.7% in 2016, with significant jumps in 2014 and 2016, whereas we can see that urban counties haven't increased quite as much. This shows that overall, polysubstance use is growing, but it is widening even more for rural citizens and residents, and specifically pregnant people. Here we will describe the issue through the socio-ecological model. We're looking at the issue in a framework that looks at the health and behavior as it's influenced through the individual, interpersonal, institutional, community, and policy levels. At the individual level, there are many knowledge gaps. There's withdrawal risks and trauma that pregnant people face. When moms understand the real risks of substance use in pregnancy, they're more likely to cut back or stop and potentially get care. But education alone isn't enough. Remember, addiction is a disease. The win in the individual level is that we are pairing clear education with comprehensive care. And so this combination improves outcomes for both mom and the baby. At the interpersonal level, what we're looking at here is that relationships really do matter. You need supportive partners. Moms need supportive partners, supportive family and friends. They need help, when pregnant people are entering treatment and needing to cut back or drop substance use. And additionally, this is linked to lower use when you have this, good network of people. But stigma and judgment from loved ones or clinicians can actually push pregnant people away from care and into isolation. Ultimately, we must reduce stigma, build better supportive networks, and then recovery can become more likely. At the organizational level, when prenatal care and substance use treatment are integrated, birth outcomes actually improve. This was shown in a large cohort where there was less prematurity, lower birth weight, and fetal death. But we must remember that access is limited. Only about 19 states have dedicated programs, and many exclude polysubstance use pregnant people, and some clinics won't accept pregnant patients due to liability. To mediate this barrier, we'll talk about it later, we must expand integrated programs. We need to train providers on polysubstance care and remove certain exclusion policies. At the community level, there are community resources that shape care. When clinics and outreach programs integrate substance use care with prenatal services, like South Carolina's IMPACT program, which stands for Improving Access to Perinatal Mental Health and Substance Use Disorder Care through Telehealth and Telemonitoring, IMPACT. This offers telehealth care coordination and real-time perinatal psychiatry, and mothers can get real help. But in many rural areas, they're still facing long drives. There's not a lot of providers, and transportation is very limited. The bottom line is that we need to strengthen the local health infrastructure and expand telehealth so care is closer, more coordinated, and ultimately more doable. At the policy level, we know how influential policies can be. Certain administrations can change policies, and this can really affect certain groups of people. When states expand things like Medicaid and cover medication-assisted treatment programs along with prenatal care, then more pregnant patients can receive treatment. The flip side is that criminalizing substance use in pregnancy, like laws in some states or federally, this drives fear of potential arrest, custody loss to their baby, and keeps people out of care. And so we must choose policies that prioritize access, treatment, recovery over these punishing policies to move past these boundaries. Here we'll talk about the first intervention I propose. So the first intervention I'd like to implement is a community-based participatory research app, CVPR, which supports stigmatized and vulnerable mothers with lived experience of substance use. Mothers will help co-design the app, which will contain peer support, parenting modules, harm reduction tips in a stigma-free, multilingual, and low literacy format, specifically for those who need it. The technology is also HIPAA appropriate with a secure cloud hosting and analytics dashboard through either REDCap or OpenClinica. And as a current researcher myself, I would be fulfilling the role as the research role. We will also need personnel like a CVPR facilitator, a project manager, content designer, language line personnel for translation, an IT administrator, a trainer in trauma-informed care and stigma-free language, and development of emergency manuals and other kinds of manuals and procedures. And this relates back to the social ecological model because it increases individual knowledge and skills for mothers. It also provides interpersonal peer support for them. And there's a greater organization here for linkage to care. You have this peer support all in the hands of an app. And this is kind of what the CVPR framework looks like from Raynor study. So there's on-demand support. There's communication that's readily available. There's live support groups. There's parenting education, testimonials of people that have used it, and there's also monitoring of what mothers or pregnant people are using and how they're using it. Now we'll move on to intervention number 2. This intervention ties the Moms Do Care program for pregnant, postpartum, and parenting people. And so this program uses peer recovery coaches with lived experience who specialize in working with this group PPP. And they will lead small groups in certain community spaces. They will also maintain a weekly outreach, coordinate any kind of handoff to counseling or clinical care. I propose that language access, some sort of childcare, and transport is also utilized and included for participants. Ultimately, the goal here is this program is trying to connect families to integrated clinical care, OB providers, recovery coaches, pediatric and community providers, all through this network of PRCs. And so the ultimate goal is we're trying to move around traditional systems so that we can avoid the stigma, any kind of shame or fear, where mothers would be working with people that have lived experience and are trained to work with them specifically. The third intervention looks at rural ride support. It involves actually getting to care. I plan to help remove a basic but brutal barrier, a ride program that gets pregnant mothers with substance use issues to any kind of prenatal, postpartum, pediatric, or treatment visits. Pickups would be discreet. Schedules would definitely be reliable. And when possible, we would pair rides with on-site childcare for mothers that need it. And so going back to the SEM, the social ecological model, this is building community, it's building organizational access, and it's mitigating rural distance and any sort of reliability barriers. And so how are we evaluating this? What's the proposed evaluation, outcomes, and measures? We will propose to evaluate this by looking at a lot of things. We'll be looking at app logins, module completions, any kind of parenting resource engagement. For the PRC intervention, looking at weekly contacts, communications, handoffs to care. And for rural rides, of course, we'll look at completed versus non-completed rides, how many rides are being completed, when are they being completed. In the short term, which is from month 0 up to 3, we'll hope that for the CVPR intervention, at least 50% of people will attend at least one formal treatment beyond just enrolling the app in the MDC. We want to increase knowledge of polysubstance risk and available services to mothers. And for rural ride support, we want to decrease missed appointments for prenatal and postpartum visits by at least 25%. Our middle or intermediate goal is looking at a 20% improvement in perceived social support through our social support survey by 6 months. For the MDC intervention, we want at least 50% of mothers to be on polysubstance care retention at 6 months, and at least 75% to complete a referred pediatric or perinatal visit. For rural ride support, we just want better prenatal care adequacy, and this can be measured through the Adjusted Prenatal Care Utilization Index, also known as the APNCU. In the long term, we really just want polysubstance recovery and stable parenting improvement, sustained reduction in use of substances, consistent visits to childcare visits to be completed. And also, we just want more programs and services to be developed and utilized by this targeted population. Some potential challenges and solutions here: stigma and fear of punishment by mothers. We'll try our best in all of our interventions to have trauma-informed messaging, the best confidentiality possible, and hopefully with peer-led engagement and having legal aid partners that look at the legalities of things. This will help stabilize that. In terms of limited provider capacity and any kind of liability concerns, we need training on polysubstance care. We need clear protocols, clear manuals, and these will be written up by trained people, and also shared care agreements that mothers can go through and look at. There's also a digital divide. Some people understand newer things and digitally and also language-wise than others. And for this, we'll give off phone stipends, data stipends. We can also provide content that's offline and try our best to provide lay language manuals of procedure and doing things in a lay language manner for those that need it. There's also transport and childcare gaps. For this, we'll provide pregnant people and mothers with ride vouchers and volunteer drivers for rural ride support. And hopefully we can get funding on-site childcare partnerships so that children can be taken care of if mothers need it. In terms of data sharing and ethics, this is a big issue that always comes up. For that, I'd have a big role in that. I've developed many IRB and data usage agreements, help develop secure hosting for apps or anything that has to do with online red caps or open clinicas, having our dashboards be de-identified, having people be under IDs instead of specific names. That'd be really important to get through. So what do our partners and what do the roles look like? We'll have is a community advisory board, and hopefully we'll have mothers with lived experiences in this one. I think that'd be really important, specifically for the PRC and the community-based intervention. We'll also have CHCs, people from WIC, hopefully volunteering, shelters, any kind of libraries, community-based organizations, faith organizations that can help out in providing for us. In terms of public health roles, we'll have a program manager, a CBPR facilitator, an epidemiologist, evaluators, people that are savvy in policies, our policy liaisons. In terms of clinical partners, we're going to need OBs, pediatric providers, addiction medicine providers, PRCs, behavioral health teams, and people that are good at data and evaluation, a statistics team. My role, I am a research lead. I will develop protocols. I'll go through the IRB process, help in data integrity, data usage agreements, cross-site coordination in the case that we are a sponsor site and having other sites be part of these projects. And also helping with the dissemination to policy and hopefully getting it out to become a practice in the real world. And here's my logic model. And this logic model, it's very long. It looks at the project and kind of how it's going to go along from its inputs all the way out to its outcomes. And ultimately, what we want to do is we want to co-design the CBPR app. We want to run an MDC-style peer care group and ensure that there's rural rides to better, get through this gap for mothers with polysubstance use or pregnant people with polysubstance use as well. And so then mothers can better engage. They can be linked to treatment and attend any kind of prenatal, postpartum, pediatric visits or substance use visits. They can also receive the right social support, and MDC retention will hopefully rise over time, and we'll have less missed visits at any of these peer group or any of the clinical care visits. And finally, we just want substance use to decrease. And we want both mothers and infant outcomes to improve over 12 months. What this looks like isn't just mothers stopping substance use. It's about more than just that. It's about mothers being able to have these services at their disposal and not being limited to them. Thank you.